chemical injury. How do I? The management of ocular burns consists of management in the acute phase and in the chronic phase. The acute phase is very critical and immediate and early management should be undertaken. In the chronic phase, one needs to do correction of lid or adnexal problems, ocular surface stabilizing procedures and visual rehabilitation. The most devastating ocular chemical injuries are alkali injuries because of their increased amount of penetration due to saponification and liquefactive necrosis. Acid injuries cause protein coagulation and so limit penetration. The most common alkali injury is the sodium hydroxide injury, but one should not forget in Indian scenario, tuna packet injury is very common, and this is what we published in ophthalmology in 25 eyes, but I'm likely to believe that almost 72 to 80% cases of chemical injuries that are reported to us are because of this tuna packet injury. Important thing to notice that these are generally young children, and in almost 90% of the eyes they were grade 4 injuries, which is severe injuries. Only 8 out of these 25 eyes which we analyzed were treated by medical therapy, and almost all of them had to undergo surgery, and post-operative median visual acuity was 1/60. That is to say that the poor, they generally have poor visual prognosis, and this is the paper that was published in ophthalmology. As soon as a case of acute ocular injury comes, one has to look for conjunctival inflammation, specifically for hyperemia, chemosis, epithelial defect, size and stromal haze. And one also has to look for perilimbal ischemia, particles in the conjunctival fornices which should be removed. Double eversion of the lid should be done, and it is imperative and essential to remove any particles of the chemical that are visible. And patient may also complain of decreased best corrected visual acuity because of epithelial defects and stromal haze. In more severe forms, there may be corneal perforation, AC reaction, increased intraocular pressure and adnexal damage. There are two classifications which are given for ocular burns, originally described by Roper Hall based on limbal ischemia and corneal involvement. He graded it into grade 1 and to grade 4. But soon it was realized that 50% ocular burns, which was grade 4, did not have same prognosis as those which were 100% burns, because with the current stem cell ocular surface techniques, these patients tended to do better. So grade 4 were again divided into, this classification was further amplified or modified, so that grade 4 was further subdivided, and we had grade 6 classification system given by Dr. Harminder Dua. And this is based on the clinical findings, that is the amount of limbal involvement and the conjunctival involvement. Now, the most important thing that one needs to do is irrigation of the superior and inferior cul-de-sacs in the case of acute ocular injury with saline, ringalactate or BSS plus, whatever is available. And if all these things are not available at the primary health center, one can even use clean tap water. But irrigation is a must for at least 20 minutes. You may require 1 to 2 liters of water. Remove the foreign body, which may be a depot for chemical, and pH should be tested 15 minutes after the irrigation has been done. It should be preferably 7 to 7.3. Now, the management strategies consists of promotion of epithelialization, supporting repair and minimize ulceration, and control inflammation. And this summarizes the management in the acute phase. Preservative-free artificial tears are given along with topical antibiotics. Steroids have a role in the first 10 days or 2 weeks and should be given very frequently, because that is the only drug which is going to decrease the amount of ocular inflammation. If a pharmacy is available, topical ascorbate and citrate 10% should be instilled very frequently. And again, these are helpful only in the initial part, that is about 2 weeks after up to 2 weeks till when the chemical injury has occurred. Autologous serum may be given in those cases where there is persistent epithelial defects, and oral vitamin C. Some people even give doxycycline in severe burns to prevent melt. Anti-glaucoma medications, preferably systemic aqueous suppressants and not topical medications, because they can be epitheliotoxic, and cycloplegics. Apart from artificial tears, there are others such as fibronactin, epidermal growth factor, retinoic acid and sodium hyaluronate, which have been studied for research purposes. Steroids reduce the inflammatory cell infiltration, and they have a favorable risk-benefit ratio for up to 10 days. We like to give it up to 14 days. Medroxyprogesterone was available earlier but is not available now. It has less anti-inflammatory potency, minimal effect on stromal repair and collagen synthesis, and may be substituted for steroids after 14 days. Autologous serum has a similar pH and osmolarity as tears, but has increased amount of growth factors, epidermal growth factor, TGF beta, vitamin A, and alpha-2 macroglobulin, and hence are of benefit in cases of acute injuries. This is a paper we published in IOVS, role of umbilical cord serum therapy in acute ocular chemical burns, and we thought that cord serum, since it had a greater concentration of growth factors as compared to autologous serum, would work, and also it was a source of stem cells to treat hematopoietic malignancies. Cord serum was prepared in a internationally accepted by the internationally accepted method, which has been well described, and this was a double-blind prospective randomized clinical control trial where we found that cord serum in terms of mean time to epithelialization was better as compared to autologous serum and artificial tears. This is one of our patients in the cord serum group which epithelialized, another one in the autologous serum group which epithelialized, and this was in the artificial tear group which had limbal stem cell deficiency. There are newer modalities available such as amnion extract and topical Avastin and ACE inhibitors. We have not tried this and do not have experience with these, but they appear to be quite good. The surgical management in the acute stage consists of tenoplasty, tarsorrhaphy or tissue adhesives if there is a corneal melt, and sometimes you may have to do tectonic grafts in these cases. Amniotic membrane transplantation can be undertaken in these cases, and the last two studies which are highlighted were done at our center. Again, these were randomized controlled trials in grade 2 and grade 4 burns, and we did find that in moderate burns there was faster epithelialization. However, there was no difference when amniotic membrane was used in severe burns. So it does help in moderate burns, and as of now we do amniotic membrane transplantation in cases of acute burns, grade 3, grade 4. Now, management of chronic burns first consists of correction of lid abnormalities and procedures of stabilization such as limbal stem cell deficiency and COMET, and visual rehabilitative procedures. If it is a unilateral stem cell deficiency, you can just do amniotic membrane transplant because that causes in vivo expansion of the stem cells that are already present. If it is a total limbal stem cell deficiency, then you have to take the limbus either from the fellow eye or from a relative, or you can even use the cadaveric limbal lenticule. In cases of bilateral stem cell deficiency, if it is partial, again you have to take a limbal lenticule from the relative or from the cadaver, and in cases of total limbal stem cell deficiency, again a live related donor has to be taken or from the cadaver. But important thing to understand is that whenever you use live related donor or a cadaver, then you have to put the patient on systemic immunosuppression. These are two of our cases in which live related limbal stem cell transplantation was done, and although the vision is not 6/6, but they do have ambulatory vision. Two of another of our cases where cadaveric limbal stem cell transplantation was done. The only problem is that you have to give systemic immunosuppression in these cases. Another technique which was described was that you can take a full thickness graft, and in that only you can take a limbus. That is a keratolimbal graft which is shown here. So it will give limbal stem cells from the eccentric portion that is cut, as well as will cause visual rehabilitation. Again, in these cases, systemic immunosuppression is required. We described the technique of large diameter lamellar keratoplasty because we thought that if you use a 12 millimeter graft, not only would you be giving limbal stem cells, but also you would be rehabilitating these patients visually at a single sitting. So these are two of our cases, and we published this in ophthalmology. But again, you have to give systemic immunosuppression in these cases as well. The currently used technique is a limbal stem cell transplantation, wherein limbal lenticule is fashioned from the fellow eye, which is normal, and it is always important to rule out that there is no limbal stem cell deficiency in the fellow eye. And this is dissected with the help of a blade breaker and subsequently with the help of a crescent blade. In case you do not have facilities for cultivation, you can transplant this limbus alone with the amniotic membrane, and in vivo expansion of the stem cells does occur. But in case a lab is available, then these have to be grown in the laboratory over the amniotic membrane. And then subsequently these are then transplanted onto the eye which has a stem cell deficiency. Now this is a case of total stem cell deficiency in which the pannus is removed from the cornea, and this is done with the help of the lamellar dissectors and the crescent blade. And following the removal of the pannus, the amniotic membrane is then taken, on which the limbal stem cells have been grown in the laboratory. And these are the small pieces that you see are of the limbal lenticule that had been harvested from the fellow eye. And this is then sutured onto the patient's cornea. This can be glued or can be sutured. I always like to put some sutures because this is a precious tissue, and if gets displaced, then you can't obtain stem cells again. So these are the various studies which have shown that limbal stem cell deficiency has a success rate of 60 to 80% for ocular stabilization, and it does cause improvement in the best corrected visual acuity by 2 or more lines. Now, in cases of bilateral limbal stem cell deficiency, you can also do what is known as oral mucosal epithelial cell transplantation, or COMET. That is, you can take the buccal mucosal membrane and cut it into pieces just like limbus, grow it on the amniotic membrane, and you can transplant it. The advantage is that there is no systemic immunosuppression required because you are taking the patient's own buccal mucosa. And this is what actually was a cohort of 16 patients who were traveling to Rampur, and their truck fell into a ditch which consisted of sodium hydroxide as an industrial effluent. And these are the follow-up pictures of 31 eyes over a 2-year period. And this cohort actually helped us to understand the natural history, but the treatment history of acute chemical injury, because it was the same chemical which had injured these eyes. And notice some of the eyes did well, such as this case which healed, but there were some which had limbal stem cell deficiency, some which had perforations such as this, and we had to do a tectonic graft for these patients. And some of them, there were even infections such as this, and the patients, they went into thysis bulbi. And ironically, the patients who were younger did better. Maybe their reflexes are faster, so they probably jumped from they quickly got up from the area. But this just helped us to understand, and we did use stem cell transplantation, keratolimbal grafts, amniotic membrane transplantation, all the procedures that we possibly could use in these patients. And this paper is now accepted in American Journal of Ophthalmology. With this, I would like to say that acute chemical injury is best prevented, especially the tuna packet injury, and it is important more to educate the public about this injury so that it does not occur, because once it does occur, then the management can be quite difficult. Thank you for your attention.